Hello everyone, and welcome to this Children's Safety Network webinar on understanding and using injury cost data. We appreciate you joining us today, where we'll be learning about how to get injury cost data, exploring ways to use cost data to further your injury prevention efforts, and we'll see an example of a cost-benefit and cost-effectiveness evaluation. I'm Jennifer Allison, the Director of the Children's Safety Network, and I will be moderating today's webinar. So one of the first things that I want to do is just review a few quick technical tips. Audio is going to be broadcast through your computer speakers. If you have trouble with audio, please dial 866-835-7973 and mute your computer speakers. You can use the question and answer box on your left at any time to ask questions or make comments, and we will get to those questions towards the end of the webinar after the presenters have shared their information with us. Then I also want to call your attention to the fact that there's a file share pod right above the slide deck, and there's a PDF of the slides for this webinar in that file share pod, so you can download that from there. Also want to let everyone know that you're going to be muted throughout the webinar, and finally that this session is being recorded. Now I'd like to introduce the presenters for today's webinar. Our first presenter is Rebecca Spicer, who's a senior research scientist at the Pacific Institute for Research and Evaluation, and she's the director of the Children's Safety Network Economics and Data Analysis Resource Center. So she's contributed to the field of injury control research for nearly 20 years, and her expertise includes evaluation, cost analysis, and study design. Dr. Spicer has a special interest in measuring the burden of injury, including updating methods for determining quality of life impacts resulting from traffic-related injuries. And before her career in public health, she was a Peace Corps volunteer in Tunisia and Gabon. Dexter Taylor is going to be our second presenter. He's a data analyst and technical assistant specialist for CSN's Economics and Data Analysis Resource Center, and he's an associate research scientist at PIRE. Dr. Taylor has 15 years of health-related research and program experience, including injury prevention, technical assistance, capacity building, health communications, and program monitoring and evaluation. And his research and programmatic work focuses on violence, unintentional injury, substance abuse, and health disparities among vulnerable populations, such as youth, the elderly, and minorities. So I want to welcome both of our presenters, and at this point I'm going to turn things over to Becky. Becky, you can go ahead.
Great, thanks Jennifer. Welcome everybody. And Rebecca, do you have the results from the poll we put together in the waiting room there? So I was wondering if y'all could take a look at the poll, just quickly answer how you've used cost data in your work to prevent injury. And if you haven't ever used it, that is great news also, because there will be a lot of good information later in this presentation. So it does look like a number of you, nearly half, have used cost data in your work to prevent injury. And I hope that this presentation will have a little something for everybody and that you can take away. So why use the cost data? We know that incidence data or cost data, incidence data or counts are really useful for assessing the magnitude of the problem, assessing risk. But counts can really only tell part of the story. So we use costs to measure burden by accounting for multiple injury consequences. That means death or severity, disability, body region, nature of injury into one single unit of measurement. So essentially we're using costs and weighting it by severity and type of injury to come up with one single measurement. So Rebecca, you can put the poll behind the screen so we can just see the presentation. So to make my point, you'll see that emergency department treated and released injuries account for most of these injuries to 0 to 19-year-olds in 2012. Hospitalizations account for 3%, and fatalities are really just a small sliver at less than 1%. But when you look at the cost of these injuries, the medical, the work loss, and quality of life costs, the pie looks a lot different. So by adding these measures of medical spending, quality of life loss, the impact of disability impairment, of the severe hospitalized injuries, and fatalities, it puts this picture, and it looks very different. And in 2012, injuries to kids and teenagers cost society $594 billion. We know that injury is the third leading cause of medical spending in the United States. So this slide gives you an idea of how we might compare injury medical spending to other conditions. It's the third leading cause of medical spending. These are injuries that were treated at doctors, at physicians' offices, emergency departments, and hospitals. Fatalities are not included in this pie. So the reality is that medical spending for fatalities is really quite small, and when we're talking about medical spending, we're really just talking about non-fatal injuries. So you might ask, how do we measure the impact of death and disability in our lives? And cost is one way to do this. So generally, we use three cost categories. Medical spending includes emergency medical care, acute care, rehabilitation, follow-up care, long-term medical and institutional care, prescriptions, ancillary expenses, coronary services for fatalities, and the cost of health insurance claims processing. Work loss is productivity losses. It includes wage, benefits, and household work for adults. For kids, it includes work that parents would miss treating for their child. It also includes short-term work loss, and it also includes long-term work loss if the child is killed or permanently disabled. Then the quality of life costs place a dollar value on the pain, suffering, and lost quality of life that children and their families experience due to death and injury. So for those 2012 injuries among the 0 to 19-year-olds, quality of life costs make up about 84% of the total comprehensive costs. And while they are somewhat intangible of value on life and quality of life, they are really important to our field because injuries are the leading cause of death among our kids and teenagers, and it's important that we know that we be able to measure the burden of that. This slide shows the contribution of different levels of treatment and death within each cost category. So again, the bulk of medical spending results from those non-fatal injuries. You can barely see that sliver of pink for fatal injuries. Hospitalized, in particular, fatal injuries contribute in larger portions to work loss and quality of life loss. So really, costs are a measure of severity, and this presents average cost per hospitalized injury for select causes. More severe and debilitating injuries will result in higher costs per injury. Work loss costs are a really good measure of the long-term consequences. So this graph presents average cost per hospitalized injury for select causes. And you can see that motor vehicle crashes have particularly high costs. And this may be due to the particular contribution of traumatic brain injuries here. So that was really just a quick overview of the cost of injuries in the U.S. And we really wanted this presentation to be more practical and useful than just a description of the costs. So my colleague Dexter Taylor will present a useful tool that the CDC developed to help in cost analyses.
Okay, good afternoon, everyone. Well, before discussing the use of CDC's Whiskers cost module, we'd like to get some responses to your poll question, so regarding have you ever used CDC's Whiskers? I see we're progressing through. Um, Surprising, nearly half of you as of now haven't used Whiskers. This is good because you'll find it very handy. Um, Very few for mapping, uh, and also very few for cost reporting, which is important. Um, I'll just see if the pattern changes. And I think we're on a fixed pattern here, mostly for leading causes of death and incidence reports, as I expected. But I'm surprised that so few have used Whiskers. Um, well, Whiskers is the web-based injury statistics query and reporting system, so it's good that they call it Whiskers instead of all of that. um, uh, what we like to do here is uh, first sort of do a walkthrough on developing a cost of injury report. Here you can find Whiskers at cdc.gov/injury/whiskers. And you see on this face page, and as you indicated in your response to the query, they do a lot more than provide cost information. But if you look at the bottom of this face page, there are several button options where you can go into the site and get data, fatal injury data, non-fatal injury data. And among those 6 buttons in the bottom quadrant there, the bottom right, you'll see the arrow pointing to cost of injury reports. That's the portion of the site, of the module that we'll be working through today. So what type of data are provided there? Well, there's a rich set of sort of individual selections and sort of cross-tab or combined options you can query for creating custom cost reports. It starts with 3 levels of treatment: death, hospitalization, and ED. And then those data can be classified into 2 broad schemes for further analysis. First, by cause of injury, and that includes the intent mechanisms or crossing of intent mechanism, and also a scheme by body region and nature of injury, or crossing of nature of injury. And here we want to point out that when we discuss nature of injury, we're not, again, talking about cause, but more here about whether it's a fracture, a sprain, and so forth. So, in addition to those categories, you can create custom analysis on the following sort of demographic, geographic, and statistical characteristics, including sex, age or age group, medical costs, work loss, or the combination of 2. Note that quality of life is not among those cost options here. You can select geographical options for national, regional, or state level pricing, and also index the price to a specific calendar year, 2012 year cost, 2013, 14, or et cetera, going back to 1999. And conveniently, Whiskers has a rather comprehensive injury reports help menu, and the link is provided here, and you'll find a detailed discussion of how these costs are calculated and the operations of the site itself. So to create a cost of injury report, you have to work through a series of screens. You'll see here the indication that this is screen 1 of 3. So you'll be presented with 3 screens, and each screen has a small subset of options that you would have to work through to create your report. So here in this first example, we're going to work through a series of examples looking at the cost of unintentional motor vehicle deaths for 10 to 19-year-olds. So the initial selection one would make is the death as a level, and then intent and mechanism as a classification scheme in this initial screen. So the second screen allows you to sort of describe the more nuanced or detailed intent, mechanism, or cause information, or if it were similar in the sort of body region or nature of injury, the layout is it's the same, and you would describe sort of the nuanced characteristics of your query or your cost report. Here, the first option you have to select is the mechanism level, and the various levels here mirror the International Classification of Disease description of injury, where the description gets more and more specific. You'll note that it moves from motor vehicle traffic to motor vehicle traffic occupant, and that starts with a more broad sort of all mechanisms. So that option must be selected before you're able to navigate down on some of these other particulars. So here we select unintentional for our example here, and then an arrow here pointing to the motor vehicle traffic. That is the characteristics that we're looking at as far as the intent and mechanism. There are several options on the third screen that in many domains, geographic, demographic, report options, statistical options. We're not going to go into all of those at once. We'll talk about others as we progress through. But for now, we'll rely on the default options for all but the demographic option, where here we will create a custom age range of 10 to 19-year-olds for this example. And this is the last screen before you generate your report. You'll notice that the generate report option is here. And for some of you, you would simply click a generate report request. But what happens for many, and unfortunately the pop-up block is not as clear as this sort of indication I've presented here, but typically it's a very small indication in the address bar, noting that your pop-up has been blocked. And some people might experience the request to generate a report that has nothing happening if they don't notice that little image there. So in order to get a report which is presented as a pop-up, you'll have to allow the pop-ups on this site or more generally. And this is what you would get for that report. You'll get the average costs, which are noted here, and which are the same as the unit cost for medical and work loss, and the total cost, and you will get an indication of the combined costs. And the characteristics that you previously specified in screens 1 through 3 are also laid out for you there. You're also provided with other options for downloading or printing the report. You'll see here there's a principal view that you can request, or an export data request where you get something that's more suitable for putting in an Excel file. The principal view is a PDF file. And if we move forward, you'll see that the printable view conveniently provides sourcing information for the data. It's a complete package, a complete description that's ready to insert in any of your reports or any documents that you like to share. And for the remainder, I'll skip through the various options of reporting for our examples and go straight to the printable PDF report. So we focused there on, so that previous report was a national report, that sort of the cost for 10 to 19-year-olds of unintentional motor vehicle deaths nationally. The module also allows for geographic-based descriptions. And here, if you assume you were within a single session and you move back to screen 3, the assumptions that you made or the choices you made in screens 1 and 2 still apply, and you can modify your cost report request to select a specific state. So here we've selected Maryland, and we're going to generate a report for the same base year, 2010, with an age range of 10 to 19. And If you move forward there, you'll get a report that specifically describes the cost of unintentional deaths, motor vehicle deaths in Maryland for age 10 to 19 in the year 2010, similarly with detailed sourcing information. Now, so let's assume, again, in the same session that you had your own data and you wanted to describe a year different from what was generally provided. To create a report based on your own data, you have an option in the report option window at the very top. You'll see we've been relying on the generate reports so far with national data, but here you're allowed to generate a report with your own case counts. And in this instance, you would have to specify the year of the data because you're providing your own data. The module doesn't know, so you have to share that information. You can choose a single year where you would say the start and end year are the same, or a range of years. Here we're selecting year 2014, and we're choosing a cost, an indexed cost to the year of the data. And in most cases, that's what you prefer. In some cases, it may vary. And you might note that different from the previous screen, there was a generate the report option here. In this case, you're not asked to generate your report, but you're asked to enter the case counts. And I previously sort of looked up the reports and for Maryland in the year 2014, and there were 25 deaths for 10 to 19-year-olds due to motor vehicle crashes. So when you're generating your own report, you're asked to enter that specific value, the number of deaths. And also, very importantly, you're asked to create a subtitle to your data. This is important because you may be entering data with some unique characteristics. It may be a particular quarter of the year. It may be a particular county. But those characteristics it's essential that you provide those in the generation of the report so that the final printout has a complete set of information that you would use. And here you see the familiar sort of generate report option, which you would click. And then once we move forward there, then you get the report familiar to what you've seen before. Okay, so far we've focused on unintentional motor vehicle deaths, but as we mentioned earlier, the module does provide cost information for non-fatal as well as fatal injury. So what we're going to do now is quickly walk through an example using hospitalization data and create a custom report based on our own data for the state of Maryland. Here again, in screen one, you select the level of treatment that you're interested in, and we've clicked hospitalization. We're continuing with our scheme of intent by mechanism or cause. And there are various sources of data. In our example, we're using the Children's Safety Network's state fact sheets, which will provide the sort of information that we need for our cost of motor vehicle crashes, unintentional motor vehicle crashes. But we also have a poll question, and we want to find out your familiarity or your use and how you might use these fact sheets by CSN. Well, and you see at the bottom of the page, we're relying on Maryland as an example again. So there's the link to the specific Maryland 2016 fact sheet, which has year 2012 hospital admission data. And there's also a link to the more general state fact sheets, which you will find similar descriptions of data for each state and more than just the state fact sheets. And further, the state fact sheets, in addition to the hospital admission data, provide a detailed discussion of motor vehicle crashes, suicide, and drug overdose among children and adolescents. And we see that more than half have never used them, and I'm happy to introduce you to them. And most use them for community education and some for injury surveillance. Yes. Oh, and proposal development, of course. Yeah. It looks like we're settling, at least often used for evaluation among those who use them. Okay, so nearly 60%. That's a lot of new users. I'm happy. Okay, so here what we've done is the cost we're looking at here is the motor vehicle occupant, 10 to 19-year-olds in the year 2012 for hospital-admitted injuries. And we see there the value is 217 incidences, 17 incidences. So now we'll return back to the familiar screen 2, where you would identify the mechanism level and sort of the nuanced description of your intent sort of mechanism query. And here, again, the first choice you must make is the mechanism level, because that activates some of the options further down in this list. And without your selection of the level here, some of these lower options won't be active. So here again, we choose unintentional, and we choose motor vehicle traffic occupant. And you might notice, if not now, later in your use, that the layout is somewhat different for this screen 2, these nuances of intent by mechanism, and that's largely because the coding, the International Classification of Disease coding for mortality and for hospitalization are different and in a way that requires a different presentation and analysis here. So if we go further, again, you would have to identify the year of your data, and here is 2012, and we're costing to that year. Request that the report be generated as opposed to the national data, and specify 10 to 19-year-olds. And again, you would click the enter case counts. Click the enter case counts here. And then you'll get essentially, as before, the fourth screen, when you're generating your own data, the next series of options, where we would enter the 217 cases. You see here, medical unit costs and work loss unit costs are provided. It's important, again, that you enter a subtitle, and then to describe the nuance of your requests of your data, unique characteristics of your data. And then, as before, you generate your report, and you get a similar table. Now here, it says United States because you're selecting out the portion of the United States that's attributable to Maryland. And the print is a bit fine here, but this is where your subtitle would appear. And you should be careful to make that a detailed description. And you will also need to provide additional source information for the data that you've brought in to this query. So that sort of walk you through a few examples. Now I will sort of return to continue our discussion about why you might need to create these types of costs and how they might help you in your efforts. So I'll return the mic to Becky to answer more of these questions.
Hey everybody, thanks so much, Dex. That was great. So I'm sure that you all really want to leave the webinar right now and go play with Whiskers, but hang on, because I thought it might be useful to talk about, once you have your costs, how might you use them? So when I think about it, usefulness of cost analysis, I think of priority setting, I think of education and communication, I think of selecting interventions. So in priority setting, say that you have 100 hospitalized fall injuries and you've got 6 traumatic brain injuries. So which one do you want to address? You only have so much money, so you've got to address one or the other. How do you know which one to address? Well, obviously it's going to be a decision that you're going to base on other issues, and it'll be informed by the resource that you have. But using costs allow you to compare these different problems using one common unit. So let's compare the cost of falls versus the cost of traumatic brain injuries, and then decide how you want to allocate your resources. And the reason it's useful is because cost of injury places this greater weight on severe non-fatal injuries like traumatic brain injury compared to falls, which tend to be very common but less severe. So now you have one metric to use in making your decision. It'll just help you out. It won't make your decision for you, but it'll help. So for example, we put together the leading causes of hospitalized injury costs in the United States for 2013. This is hot off the press. I just created these. The leading cause of hospitalizations, the leading cause of hospitalized injury costs are falls for 0 to 14-year-olds and motor vehicle traffic occupant injuries for our teenagers. You'll see that as costs go, the intentional injuries, self-inflicted, and assault injuries become much more important in these older age groups, in particular among our teenagers. So if you put together a table like this, you might be able to think about do you want to address your leading causes of injury costs? Another way to look at it is to look at research priorities. It was a question that we asked quite a while ago, so this is a bit outdated. But we were looking at the research priorities, and we were asking, are federal funding patterns for healthcare research balanced? You know, where balanced means that the funding directed at a problem is proportional to its relative burden. And in this case, we used burden as medical spending, and a second measure, years of potential life lost, which are among the collection of 3 bars. It's the 2 on the left, the solid blue and the first one, the light dotted blue and the solid blue, and then versus research spending for that issue is the checkered blue on the right. So this is one way we've used costs before. And then in education or communication, the message is really important. So we want to convey injury prevention in a way that captures the attention of policymakers, the media, the public, or stakeholders, injury prevention experts, etc. We know that there's value in prevention, and this is one way to communicate that. It shows the value of prevention when making decisions with limited resources. So you might want to consider the costs and benefits of a program. Often decision makers, they listen to the costs. And the CSN Data Center has analyzed about 168 different interventions. This is really just a sample. We have a document that I'll give you the link to in just a minute, but this is a select sample of probably the more common interventions, and we've analyzed the costs and the benefits. So every dollar spent on a child-proof cigarette lighter saves society $77. Or let's say every dollar spent on a smoke alarm saves society $17. Dollars talk, and it's one way of communicating that. And this is that resource, and the link to the resource on our Children's Safety Network website. And who is paying the cost of these injuries? Who benefits from injury prevention programs? Certainly, preventing injuries, they will result in lower disability. They'll prevent work loss and quality of life losses. But beyond that, who else is going to benefit from injury prevention? There are other payers, and communicating that can be useful. For example, let's talk about insurers. every bicycle helmet insures $41. That's $12 in auto insurers and $29 for health insurers. Here's another question. What's the government spending in terms of Medicaid on injury? In general, the contribution of Medicaid to injury medical spending is usually about 1/3, but these are presented the most significant contributions of Medicaid to these injuries: unintentional firearms, assault injuries, bites, stings, hot substances, and poisonings. So could you do these cost analyses yourself? So this is where I thought we would present a real-life analysis. This is something we did about 10 years ago, 12 years ago. So the data are a little old, but I thought it'd be a really good example of how feasible it is for you to do your own cost analyses with just the right tools like Whiskers. So the backstory on this was that pediatricians in Central Harlem were seeing a lot of injuries to kids, and they wanted to know if their injury rates were any different from neighboring Washington Heights. So they looked at the data from their Northern Manhattan injury surveillance system. They were interested in assault, gunshot, outdoor fall, and traffic injuries among kids ages 5 to 16. And like I said, these are pretty old data, 1985 to 1988. And they found that among Central Harlem kids, there are 568 hospitalizations in those 4 years versus 818 in Washington Heights. Now, it sounds like there are more injuries in Washington Heights. There are. But if you want to look at the rate of injury, because Central Harlem is much smaller than Washington Heights, it turns out that the injury rate, the hospitalization rate among kids in Central Harlem was 1.5 times that of Washington Heights. So for every 2 kids injured in Washington Heights, 3 were hospitalized in Central Harlem. So this was really the impetus to take a look at the costs. And let's go back real quick. What I thought I'd present today is kind of how I took the data, and they're in an ICD-9 format, the codings format, and I translated them into body part and nature of injury so we could use them with Whiskers. These stars here, they represent case counts. So we used Whiskers to compute just the medical spending on these injuries. And we went through the same slides that Dexter showed you, hospitalizations. I'm going to enter them by body region and nature of injury. I'm using them at this level, body region, where I'm selecting all body regions and all natures of injury. Our data are really old, so this is actually quite irrelevant, and this is just an example. The base year dollars at 2010, so we're comparing the same year's dollars. These are costs for 0 to 19-year-olds, and that's important because work loss and quality of life costs will vary by age. And then we entered them into these number of hospitalized by head neck fractures, head neck dislocations, etc. Just like Dex showed you. And we came up, and here's the summary table, with this summary table. Medical spending in Central Harlem, about $13.6 million. Washington Heights, $21.6 million. Medical spending in Central Harlem was about 1.37 times that of Washington Heights per 1,000 children. So the impetus was, the result of this was that they decided to implement a program called the Harlem Hospital Injury Prevention Program. And it was implemented in late 1988. So remember, these injuries were from 1985 to 1988. Late 1988, they implemented the Harlem Hospital Injury Prevention Program. And so I thought I'd show you the example of the benefit cost analysis we did of the Harlem Hospital Injury Prevention Program using the same data. So just a quick recap, the Harlem Hospital Injury Prevention Program, it's a hospital-based program targeting assault, gunshot, outdoor fall, and traffic injuries among kids ages 5 to 16. Again, implemented late 1988. Same data, the Northern Manhattan Injury Surveillance System. We used a design that would help us control for any outside factors that were causing injuries to go down anyways or to go up. So we used a case control study, Central Harlem versus Washington Heights, and we compared pre-intervention costs versus post-intervention costs, expecting that any decline that we see in Central Harlem that's above and beyond the decline seen in Washington Heights, we'll attribute that to the Harlem Hospital Injury Prevention Program. So that was how we used Washington Heights as a control hospital. And down here, you'll see that's the source of this study. It was published in Injury Control and Safety Promotion in 2004. So what we found was that, let's see, there we go. So the data looked like this. So here are those pre-intervention counts that I already showed you. We added the post-intervention counts, entered them into Whiskers, and came up with this more detailed description of the costs that we computed. So during the 4 years prior to implementation, the injuries among 5 to 16-year-olds due to false traffic, firearm, and assault injuries resulted in $698,000 per thousand kids in Central Harlem versus $508,000 per thousand kids in Washington Heights. In post-intervention, the costs declined in both areas, down to $420,000 per thousand kids in Central Harlem versus $420,000 in Washington Heights. So that is a 39.1% change in Harlem versus a 17.3% change in Washington Heights. So if we assume that Washington Heights is a good control site, then that 21.8% decline in Harlem that's beyond the decline seen in Washington Heights, we'll attribute that to the program. So the 21.8% is 39.1 minus 17.3. So let's assume that the decline in Washington Heights was due to other factors that were influencing injuries, bringing them down, and anything beyond that was due to the Harlem Hospital Injury Prevention Program. That comes out to a savings of $152,000 saved in injuries prevented per 1,000 children in Harlem. The total savings being $2.9 million, $2.922 million saved by the program. So keep that number in mind, because let's do our benefit cost analysis. Harlem did a great job of keeping track of the costs of their program. A lot of it was just labor costs. They computed that those 4 years of the Harlem Hospital Injury Prevention Program cost about $1.2 million. If you put that into the benefit cost ratio, there's that $2.922 million in medical spending saved, averted. That's that number I asked you to remember. Over the $1.2 million spent on the program gives us a benefit cost ratio of 2.44. And voila, there is your benefit cost ratio. So I hope this was helpful. Our website has a lot of resources we showed here, plus more. And Dexter and I are happy to answer any questions that you might have. I think that we have a good amount of time, and I've seen some really good questions come up on the board. So, you know, Rebecca, I can't read the full question, so can you share it with folks? Can you? I'm going to also put us on speaker, so Dexter and I are on speaker together. Hold on. And
yeah, and this is Jennifer. I can read out the questions if that's helpful.
That would be great.
And okay, I will do that. And I just want to remind folks that if you do have a question, you can type it into that Q&A box. It's on the lower left-hand side of the screen. And as Becky mentioned, we've got a number of questions that have already come in, so I'm just going to ask away here. So one question from Tanya is it appropriate to use the generate your own report option to forecast a reduction in costs based on prevention goals?
If you have, actually that's a great question. If you have a way to enter your expected aim in reduction of actual counts of hospitalizations or deaths or emergency department visits, using the format that Whiskers shows, you should be able to. Now you can enter them. You don't have to have body part and nature of injury. You could just have the broad category of motor vehicle occupant So if you have the expected reduction in count, I would say yes, you could compute the expected reduction in cost.
All right, great. And then a question from Kathleen. Is there a source for a multiplier for quality of life costs? And she says they seem to be the largest cost category. Is there a standard or benchmark for this, i.e. quality of life costs are 3 times the work loss costs?
So that's also a good question. It actually depends on the kind of injury. So while work loss is actual productivity losses due to disability, quality of life takes into account other issues like being able to do daily activities, cosmetic like scars and burns, and so, for other categories. So depending on the injury and their impact on disability versus these other impairments, it's going to vary. So no, the answer is no, there isn't one multiplier to get quality of life costs.
All right. Then Nancy has a question about what type of strategies were implemented in the example that you provided.
Harlem?
Yeah, right.
So Harlem did a lot of neighborhood community intervening, like installing safe playgrounds, community programs for kids to go to with their free time, painting murals, things like that. And there's a good description of the program not in the document I referenced, but the document that came before that just did the evaluation and the impact on the number of hospitalizations. So if you want to email me, I can send you the description of the program. But it was community neighborhood-based intervention rather than like an individual based. It was neighborhood-based.
All right. And then an additional question about whiskers. This participant says, whiskers doesn't include quality of life costs. Is there a straightforward way to calculate and add those to the medical and work loss costs from whiskers?
So actually, unfortunately, there isn't. And the CDC actually doesn't generally use the quality of life costs. We at PIRE do use them based on the guidelines of the National Academies of Science. So there isn't actually a multiplier to use to compute quality of life. But I will say, actually, work loss costs are a really, really good measure of disability. And for fatalities, I was making the point that medical costs don't adequately account for the burden of fatalities. Work loss costs do a really good job because they apply a full life loss of productivity. And so they're a good measure of burden, even without quality of life costs.
Oh, good to know. And can you say a little bit more about the concept of quality of life loss costs? What's included in that?
So quality of life it's a dollar value on pain, suffering, and lost quality of life. And what that means is we looked at, beyond disability, we looked at these levels of impairment in, like I said, daily activities, cosmetic, for the life of me, like functioning grasping, being able to grasp, 3 others, and for the life of me, I can't remember what those are. And for each injury type, we came up with an impairment level. So the impairment level is essentially the percent of their life, that proportion of their life that is impaired by this injury. It's usually very, very small, but that little small proportion is applied to the value of a life that that economists have computed with willingness to pay studies, and for children, it's around $6-7 million. So if we come up with a proportion impaired of like 0.01%, then it would be 0.01% of that 7 million. And that's how
the quality of life figure comes up. Now, if someone is fatally injured, it's the entire 7 million.
Okay.
That helps.
Thank you. That's very helpful.
Good.
All right. And Kathy has a question about the Harlem data. She says, did you need to adjust the cost for relative value of the dollar?
Excellent question. Yes, you will always need to adjust for that relative value of the dollar so that you're comparing same year's dollars. So remember we were going through whiskers, and I said, oh, my data are so old that this category doesn't really apply because whiskers wasn't around then. But then we were at the, what is it called, the index cost year. That's when you're going to compute the cost of the injury all in the same year dollar, so you make sure you're comparing the same year dollar. And for that, in that example, the year indexed was 2010. Yes, you will always need to make sure that if you're comparing something, you're comparing same year's dollars. But if you're just presenting a description of the costs of the injuries for 2012, for example, you'll want to use 2012 dollars. So it depends on how you're using them.
Okay. And then Karen's got a question about one of the earlier slides. So she says, can you discuss the slide that shows the YPLLs are lower in injury versus other disorders? Shouldn't they be higher?
Yeah.
I believe it was the 2000 manuscript, she says.
Yeah, I know the slide, and here, is it this one? Yeah. So let's see, YPLL are these, yeah. I don't have a for sure answer, so don't hold me to this. But my guess is that vascular disease, maybe it's because people are dying young and there's a lot of vascular disease. So if you add up the number of years lost due to vascular disease, it would add up to more than that for injuries. So think about it this way. Injuries kills a lot of young people. Heart disease kills a lot of people who may be in their 40s, and you add all those up, and the years of potential life loss will be higher for vascular disease than injury. So that's my guess. It has to do with both the age of the victims and the number.
Got it. Okay. Then Carly is asking, do you have advice as to how we could calculate the cost to insurers, like the example with bike helmets and costs for auto health insurers?
Yeah. You'll need cost data that give information on who paid for the hospital bill or the doctor's bill. I think that's much more, that is difficult. There are some data sources out there like the AHRQ state inpatient databases that will give you an idea of who the payer was of the bill, the medical bill, and that's often what we've used. My colleague Ted Miller is an economist, and he has done a lot of work computing the who pays in as in auto insurers, and so actually that was his work there that I showed you on bike helmets. So you would need a data set that has information on the payer. Although, you know, if I can look back and I can talk to Ted, he may have a general multiplier that would help you determine what portion of medical spending is paid for by auto insurers among motor vehicle occupant hospitalizations. He may have that. So if you want to pursue that, send me an email.
All right, great. And then Linda has a really interesting question here. She says, is there a way to customize the data to reflect substance use injuries?
Yeah. Given just using the tools that we presented today, I'd say no. I think that if we looked into the literature, we would see that alcohol-involved injuries are generally more severe than non-alcohol-involved injuries, so that adds a whole nother complexity to it. So you couldn't just say that if 12% of injuries, so if you couldn't just say that if 12% of occupants injured in cars are injured in alcohol-involved crashes, 12% of crashes are alcohol involved. You couldn't just say 12% of costs are due to alcohol involvement, because the injuries and the crashes tend to be more severe when they're alcohol involved. So that is also tricky. You'd be underestimating the cost of alcohol involved crashes.
Okay. Another question here. How can people at the county or local level calculate cost data?
You can use the whiskers. If you have counts of injuries, either hospitalized or emergency department visits, if you have those, you can use whiskers. Just you'll just have to use your state-specific dollars costs. Right?
Yeah, and the generate your own data tab. Yeah, so you should be able to use whiskers that generate your own report option that we work through, and then you can use that county level description.
All right, I think we have time for maybe one more question here. So Kimberly is asking, can you be more specific about where to go for quality of life costs?
Let's see.
She went to the National Academy of Sciences website and couldn't find anything there.
Yeah, it won't be there. The only folks really doing quality of life costs are Higher. Ted Miller and I are really the only ones using the quality of life costs. And let's see, we will actually, under CSN's work, we will be looking at that later on in the year and publishing our cost of injuries in 2013. And they will include quality of life costs. But if you want to compute quality of life costs per injury, I'm wondering, and this may be possible, we could give you a cost per injury estimate for, say you want to, if you'll tell me what kind of injuries you're looking at, whether it's by intent and mechanism, like a motor vehicle occupant, or if it's by body region and nature of injury, for example, fractured arm, I can give you average cost per injury based on what I'm computing right now using the 2013 data. So send me an email, and I think I could probably do that.
Okay, that's great. All right, well, I think we're just about at the top of the hour, so we have to conclude the webinar, but I want to say a very big thank you to Becky Spicer and Dex Taylor for their presentations and answers to these really great questions that our participants have submitted. It's been a very interesting discussion. I know I've learned a lot, and I hope everyone else has as well. Just want to remind everybody that the webinar was recorded and it's going to be archived, so we'll be sending out a link to the archived recording to everyone who registered for the webinar, so look for that. And then we have a short evaluation form that you can see here on this last slide that we would really like for you to fill out. It's really helpful to get your feedback on our webinars, helps us to plan future webinars and ensure that they're useful to you, so please just take a few moments to fill out that brief evaluation form. And that's it for this Children's Safety Network webinar. Thank you for joining us, and we look forward to seeing you on the next CSN webinar. Thanks, everyone.
Thank you, everyone.
Thank you.